So, hello, and thank you for joining us today for another episode of Things to Know Right Now. My name is Eileen Lynch. I'm the Executive Director of Parkinson's Resource Organization. And if this is your first time with us, welcome. This video series basically explores all things Parkinson's. With us today is Dr. Ausaf Bari, Associate Professor of Neurosurgery, Psychiatry, and Radiation Oncology at the University of California, Los Angeles. Dr. Bari specializes in the neurosurgical repair and restoration of brain and nerve function. His bio is several paragraphs long, so I will skip all the details, but Dr. Bari has really extensive experience with DBS in particular. So today he is here to discuss two surgical interventions for Parkinson's: deep brain stimulation and focused ultrasounds. Welcome, Dr. Bari, and thank you for joining us.
Thank you very much. It's a pleasure to be here.
Awesome. So why don't we just jump in? How about you tell me, how did you become interested in neurosurgery, repair, and restoration?
Yeah, I guess that's a great question. I actually got interested very early on. It was actually in high school. So I used to volunteer at my local community hospital. I grew up in Salinas, California, which is, for those that don't know, it's on the Central Coast. So relatively smaller city. So I was always interested in becoming a surgeon. And up until that point, I thought I was going to be a heart surgeon. But there was one night where I was volunteering at my local hospital, and a brain trauma patient came in, and the neurosurgeon that was taking care of him was super nice and got me involved and actually allowed me to come and watch the operation. And so just based on how nice he was and his personality, that's what got me interested in neurosurgery. And
it's amazing how the influence of one person just almost randomly can change the course of your life.
Especially, I think, when it's early on, especially in high school, where I think those kind of personalities really can make a huge difference.
Well, that's amazing. The world is lucky that you had that encounter.
I think so.
Let's dive into the actual meat of today's discussion, and we'll start with the basics. Can you clarify for our listeners what is a focused ultrasound and what is deep brain stimulation?
Yeah, of course. So my specialty is called functional neurosurgery. So I think I just wanted to give a little bit of background on that. So there are many different types of neurosurgeons. Usually when people think of a neurosurgeon, they think of these big operations that are involving brain tumors. Sometimes we treat things called aneurysms, like that are involving the blood vessels, and other neurosurgeons do more spine. Functional neurosurgery is a very specific and different area of neurosurgery. And what we specialize in is typically implanting devices or treating the brain in a way that improves function by directly interfacing with the brain in different ways. And deep brain stimulation is a technology that's been around now for about 30 years. And basically, you can think of it as a pacemaker for the brain. So just like people are very familiar with cardiac or heart pacemakers, and the idea there is that when you have abnormal electricity in your heart, you can fix it using a pacemaker. In Parkinson's disease and tremor, there's also abnormal electricity inside the brain. And so basically, we know that we can fix that using a pacemaker in the brain. So it's actually a device that goes into the brain using very advanced neurosurgical techniques. And it's connected to a battery pack that's also inside the body, just under the collarbone. So it's a complete system that the patients live with, and it delivers electricity into very precise areas of the brain, and that can help improve symptoms in Parkinson's and tremor, and also many other diseases now. Focused ultrasound is another technology. It's newer. It's been around probably now about 7 or 8 years. And the idea there is that instead of putting a device into the brain and treating the symptoms that way, scientists and engineers have figured out a way to go in and actually burn specific tiny areas of the brain very precisely and in a safe manner in order to improve those symptoms. So the nice thing about focused ultrasound is there's no incision. It's not a surgery in the traditional sense of the word. So we're not making incisions, we're not making openings in the skull, and we're not putting a device in the brain. but we're using special sound waves that can be focused deep inside the brain and can actually burn a small area of the brain. And by burning that area, you can actually help the symptoms of tremor.
That's incredible. And I think that the focused ultrasound was approved for use in Parkinson's in 2021. So it's been on the market for other conditions a little bit longer than it's been for Parkinson's. But definitely it is catching on in the community. So we've been getting a lot of questions about it.
Of course.
Can you talk to us about the efficacy of each, and maybe at what point should people with Parkinson's consider these interventions?
Yeah. So in terms of like the question of which one is better or the effectiveness of the two techniques, they're very similar. So in the form that it's most commonly used, focused ultrasound is used to treat tremor. So you can either have a disease called essential tremor, where the tremor is really the main problem. In Parkinson's disease, there's a lot of different symptoms that are involved. So people can have slowness, they can have stiffness, or they can have tremor. But there's a subset of people with Parkinson's disease where the main problem is tremor. And we call that tremor dominant Parkinson's disease. And in those cases, we can also do focused ultrasound to treat the tremor. In terms of which one is better or more effective, I would say that they're both equally effective. So I wouldn't choose one over the other based on the fact that one is going to give you more tremor reduction. I usually, in my hands, I believe that both of the techniques will give you about 60 to 70% improvement in tremor on average, which means that some people get a lot of improvement. It might be like over 90%. And then we also have some occasional patients on the other end of the spectrum where they might only get like 50% improvement in the tremor, but that could still be meaningful. That could be the difference between being able to feed yourself and not being able to feed yourself. So there's a range of response across patients, but between the two types of therapies, they're very similar. So for both of them, I would expect about a 60 to 70% improvement. There are some subtleties though between the two. With deep brain stimulation, you can upfront treat both the left and the right hand at the same time in one operation.
That's with deep brain stimulation.
That's with deep brain stimulation. On the other hand, with focused ultrasound, you have to wait 9 months in between sites. So you can treat one hand and then you have to wait 9 months before you can treat the other side.
And why is that?
Yeah, so there's a fundamental difference in how the two therapies work. With deep brain stimulation, it's electricity, and electricity can be kind of turned on and off even after the surgery. So typically patients come to clinic and they see their neurologist, and the device can kind of be programmed wirelessly over Bluetooth. And because it's reversible, you can make changes to the therapy. So you're not doing anything permanent in the brain. And so if there's a side effect from the electricity, it's relatively straightforward to kind of change the programming and make that side effect go away or to minimize it. With focused ultrasound, it's a little bit different. You're actually burning a part of the brain permanently. So you have to be very careful with that technique because once you burn a part of the brain, that's permanent. And if there's a side effect from that, that could also be long lasting or permanent. So it's mainly because of a safety issue. We want to make sure that you tolerate the first side really well. And the 9 months gives us that ability to assess that, make sure there's no side effects. And if the patients are doing well after 9 months, we can go in and do the other side.
That's interesting. That's very interesting. And in terms of what effects of Parkinson's these interventions are treating, is it only tremor, or are there improvements with other aspects of how Parkinson's manifests in the body?
Exactly. Yeah, that's a great question. And there's some very subtle aspects to that. So in general, as you know, Parkinson's has many, many different symptoms. Some of those symptoms are called the cardinal symptoms, or the main symptoms that we all think about. So those are like the tremor, the slowness, and the stiffness. Typically, those are the three big ones. And so traditionally, deep brain stimulation is better at treating those three symptoms. There's a lot of other symptoms that can be present in Parkinson's disease. For example, some people have something called freezing of gait. There can be digestive issues. There can be problems with sleep, with depression, for example, mood regulation. So there's a lot of different things that are going on in Parkinson's, but the surgery in terms of deep brain stimulation, generally what we counsel people is that we're really looking to improve the tremor, the slowness, and the stiffness. Now, when it comes to the areas that we go in the brain, there's a few different targets in Parkinson's. One of those targets only treats the tremor. And so if tremor is the only symptom or the predominant symptom, then we would go to the tremor target, and that's called a VIM, starts with a V. And that's the target for the focused ultrasound too. So generally, focused ultrasound is reserved for those people whose main problem is tremor. But if your Parkinson's is more of the traditional type where you have all three of those symptoms, then the focused ultrasound is probably not the right procedure for you. Then we would recommend deep brain stimulation.
Okay.
That being said, there is another target that was recently approved for focused ultrasound where you can burn a different area in the brain, which would improve some of those other symptoms. But again, it's only approved for one side of the body. So typically in Parkinson's, that's a disease that tends to affect both sides of the body. So it's a very select group of people who would potentially benefit from burning only one part of the brain. The other is that because it's so new, that insurance really doesn't cover that in California yet.
Oh, the insurance game, which plays such a big role in treatment. I'm really curious about what you just said about the various various parts of the brain that have been approved for this treatment. And I know your specialty is more in the actual execution of these, but can you tell me a little bit about the approval process? How do they determine which parts of the brain to target, and what does that approval process look like?
Yeah, that's a good question. So in terms of the surgery, a lot of what we know from surgery and focused ultrasound is actually through serendipity. And a lot of it was learned back in the 1960s and 70s. And some of it was learned kind of fortuitously based on studies that were being done in patients at that time. So a lot of what we do in terms of which targets in the brain, we've kind of learned over the last few decades. And then basically you have to do large trials in the United States to show to the FDA that the therapy is safe and that it's effective. So there's a whole process that has to be done. It always starts with animal work and typically progresses to where you do a small trial in patients just to show safety. Once you've shown safety, then you have to go to a bigger trial where you probably test it on over 100 patients and show that it's effective. And Parkinson's approval, DBS approval for Parkinson's and essential tremor kind of went through that pathway. And then subsequently, when focused ultrasound was invented, it was a similar pathway where there was a large randomized clinical trial where patients were divided between real therapy and kind of like a sham therapy and compared their before and after scores with their tremor. And that's what led to the approval.
Interesting. So how does a doctor know if a patient is eligible for either or both of these procedures?
Yeah, so there's a process involved where we evaluate the patients. At UCLA, we have a process where the patients will come in and they'll meet with the neurologist and the surgeon at the same time. But generally, what we want to make sure, especially in Parkinson's, is that the patient truly has Parkinson's disease. And that's critical because there's many other diseases that can kind of masquerade as Parkinson's disease or look similar to Parkinson's, and they don't respond to focused ultrasound or to deep brain stimulation. So I think one of the first steps is to make sure you have true Parkinson's disease. And sometimes that takes time. So if you are just diagnosed, it may take several years to figure out whether you actually have Parkinson's disease or not. And so we typically want to wait roughly 5 to 7 years to really pin down the diagnosis. And that's typically the job of the neurologist or a good movement disorder neurologist. The other factor is that during that early period of Parkinson's disease, the medications do a really good job. So typically you wouldn't even really start thinking about anything more invasive until you've exhausted medications. And so that 5-year period, 7-year period is when the medications are doing a great job. It's only later in the disease that the meds don't work as well as they used to work. And overall, what the surgery, especially in the case of deep brain stimulation, what that does is it allows the meds to work better the way they used to work.
It's almost like a surgical booster for the medical intervention.
Exactly. Right.
So what should a patient discuss with a doctor when they're considering these procedures?
Yeah, so I think the important things to talk about are really about the quality of life. So one of the things I usually ask my patients is that if there's a symptom that's bothering them, what's the main symptom? And is it really interfering with quality of life? Because all of these, even focused ultrasound and deep brain stimulation surgery, they both have their side effects or potential complications like anything else. And so we want to make sure that the risk of these procedures is worth the potential benefit. And so part of that equation is to know whether the symptom is really bothersome enough to warrant going in and doing something that has some risk to it. So for example, a good example of that is that I've had patients that have had a severe tremor, but at the end of the day, they've told me that it doesn't really bother them. It doesn't really interfere with their quality of life. And that's a case where even though the tremor looks bad on paper or in person, you won't necessarily jump to doing something about it. On the other hand, I've had some professionals like dentists who've had a very mild tremor. And if you looked at that tremor, you'd say, oh, well, it looks kind of mild, but it interferes with their ability to do their work. And that would be a case where you'd actually go in and do surgery or focused ultrasound.
That's a really great example, actually, to illustrate that point. So how the symptom affects your life is a major consideration here. And how can a patient tell if the procedure did not work? What are some of the things they should look out for?
Yeah, so really at the end of the day, you want to see benefit from the therapy and the fact that the surgery was successful in the terms of both benefit and avoiding risks, right? So those are two things to look out for. But typically, you would have a pretty good idea once the therapy is turned on. So not every surgeon actually turns on the therapy. It's typically done by the movement disorder neurologist that works with the surgeon. So there's usually several weeks before the device is actually turned on and programmed. And it's usually at that first visit with the neurologist where you will get an understanding of what the therapy is able to do for you. And you should start to get a pretty good idea of whether it's working or not.
Yeah. And for our listeners, when we're talking about turning the therapy on, that is specifically for deep brain stimulation, which is actually a device implant. How about for the focused ultrasound? Is that an immediate results type experience, or does that take a little bit of time to take effect?
Yeah, that should also be immediate. So I would say that I've never seen a case where I've done focused ultrasound where there wasn't an immediate effect.
Wow.
So in fact, that's one of the really nice things and gratifying things about these procedures is that you can see them working immediately. And that's how we know during the focused ultrasound procedure when to stop, is that we see the reduction in the tremor before our very own eyes. And that tells us that we're on the right path and that we're in the right area. And then basically at that point, we kind of make it a permanent spot in the brain. And we can see that the tremor is significantly improved by the end of the procedure, which is usually from start to finish takes about 2.5 to 3 hours. So at the end of that time period, you should have a functional hand by the end of that.
Wow, I'm glad you brought that up because now I'm wondering, the patient is awake during both of these procedures?
So for the surgical procedure for deep brain stimulation, it's done under heavy sedation. So when we're actually doing incisions and making openings, you're not awake for that part. You're basically asleep. But for both of these procedures, we want to make sure we're in the perfect spot in the brain. So although we have very precise coordinates down to the millimeter, everyone's brain's a little bit different, and there can be a little bit of uncertainty in the exact area. So we want to make sure we're in the perfect sweet spot for each individual patient. And in order to do that for the surgery, we do temporarily wake patients up for about 20 to 30 minutes, and we turn on the electricity temporarily in the operating room. And at that point, our neurologists are in the room. We do some testing. Usually about 60-70% of the time, we don't need to make any adjustments. We're in the perfect spot, but I would say like 30 to 40% of the time, it does require a 1 to 2 millimeter adjustment. And once we get it perfect, then we put the patients back to sleep and finish the operation. And with the deep brain stimulation, it's an overnight stay in the hospital. With focused ultrasound, the entire procedure is done awake. So we don't really need to wake you up. We're kind of monitoring the symptoms throughout the procedure for that 1 to 2 hour period while we're doing the mini burns that are part of the procedure. And so since you're already awake, we can go in after every mini burn, which is about a 20-30 second mini burn. We go back in the room and we do some testing, making sure we're on target, we're in the right area, and we're not getting any side effects. And so we use that information to make any little adjustments that we need to make. And once we're absolutely 100% sure we're in the right spot, then we go and make it a permanent spot.
Okay, so with that process that you just described, the burns are permanent, correct? There's no undoing of a burn.
Yeah, so the whole point of doing these little mini burns, the test burns in the beginning, is that those are low temperature and they're not going to do anything permanent to the patient.
Okay.
And it allows us to kind of test little spots around the main spot and make sure we're in the perfect area, because those mini burns will not last more than like a few hours or a day. But once we're happy with the location and we're seeing that we're in a safe spot and we're in an effective spot, then we basically hit it with the high temperature burn, and we only do that once. So most of the time, the 1 hour is really spent using low, medium temperatures to make sure we're in the right spot. But once we make that final burn, that only takes 5 minutes.
That's really interesting. So both of those procedures are very unique, and basically involve some on-the-spot tinkering with the brain.
That's right. Yeah.
Wow. Well, we've talked about some of the benefits and what people can expect in terms of positive outcomes. What are some of the risks and side effects associated with DBS and focused ultrasound?
Yeah, I would say like the two things that most people fear the most about surgery are the risk of bleeding and the risk of infection. So fortunately, those are also very rare. So the risk of bleeding is less than 1%, and the risk of infection is about 3%. So I've been doing this for about 10 years, and I've probably done about 500 deep brain stimulation cases. And out of those 500 cases, fortunately, knock on wood, I've never had a patient that's died from surgery or had any permanent deficits from putting a wire in the brain. But if you look at the national statistics and you average that out, there's probably about a 1% or less risk of having a bleed in the brain. Many bleeds are silent and they don't do anything. But there can be situations where you could have a permanent problem because there was a bleed. So it's important. It's a serious thing to consider, and keep in mind that although the risk is very low and it's overall a very safe therapy, that nobody can guarantee you a 0% risk when it comes to bleeding or infection. And so those are the two main things you would consider with deep brain stimulation. The third thing that can happen with deep brain stimulation is that when you turn the electricity on, when you turn the device on, the electricity might spread into an area where you didn't want it to go to. And if that happens, then you would get some side effects from the electricity. But the nice thing about DBS is that you can adjust that, right? You're not doing anything permanent in the brain. You're not burning anything in the brain. So it's a matter of just changing the programming or the settings of the device, and you can eliminate those side effects. When it comes to focused ultrasound, we're not really worried about bleeding or infection because we're not putting anything in the brain, but it has its own unique set of risks and side effects. So with the burn, with the focused ultrasound, there's three things that I counsel patients about. The first thing is that the sensation area of the brain is right behind the area that we're burning. So in some patients, you can get temporary numbness in the fingertips of the hand that we are treating, or even in the corner of the mouth or the cheek. That tends to get better with time, and most patients are not so bothered by that. The two bigger risks with the focused ultrasound are the risk to speech and the risk to walking or gait. And so that can manifest as slurred speech or gait imbalance. So it's not really a paralysis, but more of an imbalance type of feeling after the procedure. And the risk of that is roughly 3 to 5%. And typically when it does happen, it only lasts a few weeks to a month. But because we're doing a permanent burn in the brain, it could be long lasting, and it can last several months or be permanent as well.
That's interesting. So the risk is relatively low and most often short lasting, but again, there's no guarantees because it's a permanent change to the brain.
That's right. Yeah.
So what do people need to know about repairing or restoring a DBS or a focused ultrasound procedure? Is that possible? Is it, if something goes wrong, what are the correction measures that are available?
Yeah, so with the focused ultrasound, because it's a brain, it's hard to go in and reverse that. So typically the good news is that if there is a side effect or a temporary effect from that, it tends to not be long lasting and usually gets better. So I've done focused ultrasound over 100 times now. And again, fortunately, nobody's had any permanent problems. I've had a couple patients that had a long lasting kind of problem with their gait, but it went back to baseline after about 6 months. And we've gotten better, actually. Over the years, we've gotten to the point where the procedure, I think, is safer than it used to be. We've made more adjustments, and there's been some alterations in how we do the procedure to make it even safer. In terms of deep brain stimulation, typically, once that system is in place, people will live with it for the rest of their life. And there's a very, very low failure rate, but because it is hardware, it is a machine at the end of the day. No machine is perfect and things can break. Although it's extremely rare, if some part of the device were to malfunction or break, we would have to go in and replace that. And that's extremely rare to have to do something like that. People often ask me with deep brain stimulation, what are the kind of activities that can you do once the device is in place? And what I tell people is that most of the activities that normal people do are pretty safe. So surfing, swimming, weightlifting, jogging, things like that are totally fine. But if you're involved in an activity that is risky, like if you're skiing or you're doing martial arts, then these are activities that could break bones in your body potentially. And so they're also capable of breaking the device. But usually at that point, that's probably the least of your worries. But if something were to break, it's pretty straightforward to go and fix the device.
What you just said about the various activities that humans can undertake after this makes me wonder if you notice any particular trends in the types of patients that are seeking out this intervention. Is it all kinds, or does it tend to be people who are more active and trying to return to activity, or do you notice any trends in there?
Yeah, I think in general, it's really a diverse group of people. I think what's common is that they're all trying to get back to some level of independence, whether that's a hobby, a sport, or just taking care of themselves. The thing that these patients have in common is that they really will talk about certain activities that are limiting their ability to enjoy their life. And sometimes it can even be social. So, for example, in tremor dominant Parkinson's disease, even if the tremor doesn't functionally affect your ability to do things like feed yourself, I've got people who are like CEOs of companies, and it's embarrassing for them to be in front of a group of people and have this tremor. And so that in itself, that to me, that's an effect on quality of life that's equally as impactful as anything else.
Yeah. We definitely explore many different ways to improve quality of life here at Parkinson's Resource Organization. It is kind of the constant drum we're beating. So we're really happy to add just a few more tools to our tool belt, so to speak, with this interview. Thank you, Dr. Bari. And can you tell us what is the best way for our viewers to get in contact with you?
Yeah, absolutely. So we have a website. It's called dbs.ucla.edu. And although it's called DBS, it will talk to you about both therapies. And there we have contact information that's available there. You can always reach out to our assistants here at UCLA. We have a patient liaison, Laura Gunson, and her information is on that website as well. And she's a great resource to reach out to. And so if there's any questions, I highly urge people to contact us through that portal.
Awesome. Is there anything we missed about these procedures that you think you should add? Anything we didn't cover?
Yeah, just a few important points. I just wanted to emphasize that neither of these procedures is a cure for Parkinson's. I think it's important to know that Parkinson's is a progressive disease. However, the procedures continue to improve patients' quality of life throughout their stages. So that's been shown over and over again that even though it doesn't cure Parkinson's, that people are better off with these therapies than without, potentially. And also, you want to go to a high volume center, people who've done this for a long time. Our movement disorder neurologists here at UCLA are extremely well versed in Parkinson's disease. They're probably national experts on Parkinson's disease. They have a lot of experience, like 20, 30-year experience and going on. And we do a high volume of cases. We do about 200 cases a year, about 100 DBS cases and 100 focused ultrasound cases. So I think we have some of the best experience when it comes to both therapies in Southern California. And just keep in mind that what's really important is a multidisciplinary approach. So the decision to undergo either of these therapies should be a discussion between the patient, a neurologist, and their neurosurgeon.
Those were all really important points. I'm really glad you brought that up, especially about the high volume centers. Practice makes perfect, and you'd rather be on the perfect side than the practice side. And definitely there is no one size fits all cure for Parkinson's. There is in fact no cure for Parkinson's, but there are plenty of things we can do to improve quality of life as we go through this journey. So again, doctor, thank you for being part of that quality of life improvement practice. Thank you everyone for joining us on this episode of Things to Know Right Now. And thank you for sharing all this wonderful information. I do want to mention that the way that this particular episode came about is so indicative of the amazing community that we have at Parkinson's Resource Organization. I received some questions from constituents about the difference between these two procedures. I threw it out to some of our experts in the field who work on DBS and in the more medical aspects of the disease. And our community is so amazing. They immediately came back to me with a whole bunch of resources and recommendations, including talk to Dr. Bari. And Dr. Bari was so willing to jump on and give us a little more information about this. Thank you, doctor. It is such a generous thing to share your time. And our community appreciates it so much, and I appreciate it so much. So all of our gratitude.
Thank you. Yeah, really appreciate the invite. And I just wanted to maybe end on the note that I think it's one of the most rewarding procedures in the case of both of these procedures to do on these patients. And I think, and that's one of the most gratifying feelings that we can get, is that when we see our patients get better after we treat them.
That's really beautiful, and I appreciate you adding that on. I was going to ask, and this might get cut, so Wendy, do what you need to do. But I was going to ask, which of these procedures do you like doing more?
I think I like both. I really like focused ultrasound because of its immediacy, in the fact that we can see people walk away with essentially a cure. And I think that's really fun. But deep brain stimulation holds a special place in my heart because it's more surgical. And just the amount of technology and technique and expertise that goes into it is really fun to execute.
That was a very good answer. No commitment on either end, but there's good things about both surgeries.
Exactly. Yeah.
Well, thank you again, everyone, for joining us on this episode. Don't forget to like this video and subscribe to our channel so you can get the latest information on what you need to know about Parkinson's. We are here to serve and help you navigate life with Parkinson's. You are not alone, and we will see you next time.